Chitab kolenjin Tililindo neitun tetutiet nito neitun en Kass TV kebeberta nebo oeng nebo ngalalet nekitindoi ak kanyoindet nemiten studio inendet ko Daktari Lawrence Murunga ne kabunu sipitalit nebo Mtrh en clinic noton netinyegei ak lung cancer. Kayengalal akobo kabarunoik chebo miondo nebo lung cancer, ortinwek cheimuch konyorunen chito mionitok bo lung cancer. Kobaten nguni amache ngalal akobo oret nekimuch kinyaen miondo nebo lung cancer kebendi tai. Daktari, before we went on the break, I mentioned that we would like to understand how this condition can be best managed, seeing that most people get their diagnosis pretty late because of the challenges, various challenges that are within this process of identification. You know, somebody might think they have tuberculosis, just a cough. Indeed. They don't go to the hospital. They just keep taking over-the-counter medications. By the time it really hits them and puts them on their bed, you know, their condition is very serious. As you continue working on sensitization of the masses to suspect themselves whenever they observe symptoms of cough and the rest that don't seem to go away, once someone is diagnosed, and even before I asked you, you know, the term cancer is just something very scary for very many people.
Indeed.
You know, not many people report a positive diagnosis of cancer and then live very long. You know, many people whom we know, they battled with the problem, the various types of cancers. For a while they got better, then the remission, and then they got back again aggressively, then they, you know. So probably there's an issue of fear of the unknown. People sometimes say, ile kitu haujui itakuwa. Unaona? So because I think the mental aspect of it, where someone, the moment they get a diagnosis of cancer, whichever cancer it is, they just give up.
Indeed.
They're like, okay, mambo yangu kuisha, leteni shamba niwagawie, hii maneno yangu imeisha. So people get that hesitance. They don't want to go and find out. They just like, wacha bado nimeze dawa nisikie. Ikipoa, haikuwa cancer. Iko sawa. So probably maybe just address that issue of, you know, society being a bit hesitant to explore these possibilities.
Indeed, Victor. And that's one of the biggest, you know, elephant in the room, where we are fearing the unknown. And the unknown here is, we don't want to know whether it's cancer or it's not. We just want to be. That is the path of late diagnosis. That is what yields individuals in coming in for help when it's late. Yes, when it's late. The other thing is the procedures that are involved. You know, we tell someone tutaka tuchukue nyama kidogo kwa mapafu. Anasema nyama? Hiyo wacha nini nyumbani nifikirie. Then they go one way. They don't want to come back. The message out there is we want to ensure that when you find yourself in a situation whereby you're having a condition, get to know it. Because when you get to know it, it's going to save someone next. It's going to help you get the best of intervention. Because then you may be hesitating, thinking, let me take this medication and I'll get better, and yet you're making the situation worse. There are many myths and misconceptions at this point I just want to mention that surround the lung cancer diagnosis, or generally all cancer diagnoses. Wanasema ukionesha cancer kisu, you spread it. Remember, there are things that I said earlier when doing a biopsy, that you have to have a coaxial needle and a gun. Now what happened is that the coaxial is like this pen. This is the needle. Okay. But it has a sheet, it has another one. So when it goes in, it is the inside that picks the sample. And when you pull out, that sample does not contaminate your surrounding tissue. It goes inside the tissue where you need to pick a sample.
You pick it.
You go in, then you shoot, that is the gun. Then you pull out the sample. When you're pulling out the sample, the needle is protected, the one that has gone into the cancer cell is protected by the outer ring. So that then it doesn't spread. So that is a very, very meticulous exercise that ensures you do not spread the cancer.
Within the lungs or other
within,
organs.
oh yes, exactly.
Yeah.
So that only the area that has been targeted, you pick the sample from it. Now, what that has made is that there is almost 100% protection that when that biopsy is done, only the cells that have cancer are picked and they don't spread. So the instance where you're thinking that this will go to spread is 0. If, with that knowledge, if then it means therefore that the incidence is 0, then it means that if you are asked to go in for further evaluation, do not hesitate. Take up the initiative and go do this. The biggest challenge that has fueled these myths of cancer, that particular cancer, then your story is gone, is because most of this cancer is diagnosed late.
Yeah.
But not because it's diagnosed. We've seen individuals who have been diagnosed early and they survive. We have seen that. In our lung cancer cases, we are still grappling with that. But in many other cancers, cervical cancer, breast cancer, we have seen individuals who have lived 5-10 years after it has been diagnosed without necessarily having any experience of other. Okay, especially ladies who get cervical cancer and it's diagnosed early. Most of them just go through a procedure in line with what the cancer is. If it's still contained within the cervix, then the whole cervix is removed. If it's within the uterus, the whole uterus is moved. And so is the lung. If lung cancer is diagnosed early without spreading, then the surgical intervention is the best way to go. Okay, you go into the lungs. You can still work very well with half your lung, one part. Okay, you can even do well with one lung. You may not run a marathon, you may not run up the stairs, but you still have your oxygen and you still live, especially if it is identified early. So I'll urge everyone, if you're in a position to suspect, get diagnosed.
To just rule out.
Best treatment is, the best mind settling is when you've gone out there and they've found out it's not lung cancer. Then you can sit and swipe your tea and take your other treatment comfortably, rather than you imagining it should not be and yet it is. So that then delays the cascade of diagnosis, and it may then plunge you into the other categories of individuals we are diagnosing very late within the cascade.
So based on that, the most effective treatment option is if it's still contained primarily in the lung, then you just cut it off.
Yes.
If it's the whole lung,
or part of it,
with one lung, half of the lung,
or part of the lung.
Or part of the lung.
Indeed, that's the surgical intervention. And you see, now we are now thinking about treatment modalities. And remember what I told you, it's been very difficult for us to get stage 1 and stage 2, and therefore we have not been practicing surgery per se. And you see, sometimes this surgical intervention may follow up with something else like radio or chemo. And all these things are targeted. They need to go to an area and find and sweep clean. If there are any cancer cells, then radio or chemo can be able to clear it out. But in most cases where this disease has metastasized to other sides, either part of the lung, the other collateral lung, or the brains, or the other body parts, it becomes very tricky. Even with interventions that we know, it becomes very tricky. Currently, the advanced world is that we're looking at improvement in the treatment with the introduction of immunotherapy or targeted therapy. It is an initiative that is very well being embraced. The only challenge with the immunotherapy or targeted therapy is that it's an expensive initiative, because for you to get that medication, on average, it may cost you between 500,000 to 700,000 shillings per dose per month. So it's an expensive initiative. What you're doing as a project is that we have opened doors to partnership. And we are glad to say that AstraZeneca, the drug company, has come on board to really be very key in assisting us to access this treatment for patients who are not able to. And even for patients who are able to, but they can be able to go into an agreement that has shared cost, because it's an expensive drug. So what you're doing is that we are looking at EGFR testing. EGFR is the further characterization of these particular samples to see whether we are having a positive alignment to EGFR or we are not. And in that case, every patient who comes up to be positive with EGFR, then they are put into what you call targeted treatment, because that treatment, in this case we're talking about Tagrisso, the treatment, is actually an oral treatment, but is a is a targeted therapy that targets the positive cases with GFR.
Okay. We
are privileged to say that this is an intervention that is actually within Mtrh and Faro Hospital.
Okay.
And in this region, and I suspect probably in Central Eastern Africa, probably Sub-Saharan region, is one of the facilities that are privileged. Public facility that is privileged to offer EGFR testing within the Republic of Kenya. Others are private. And therefore, we have access to one of the most advanced diagnostic evaluation within our reach at Mtrh and Faro Hospital. Okay. So EGFR testing is there, and we are embracing initiatives that will see to it that these samples are further characterized so that if this patient is embracing a treatment modality, it is treatment modality not in the dark, but it's targeted, very targeted. Okay. There are many other panels that can come up. EGFR is not the only one. Okay. We have many others, but right now I'll talk about EGFR because it's the one that we have. Patients who are testing negative, then we have to put them on the conventional treatment for chemotherapy. That's the one that we have. Because remember, sometimes we do radio and chemo, sometimes we do chemo, finish, then we do radio. Or do radio, finish, then we do chemo. Because that is basically the options that you are left with, because the surgical intervention then is past, because most of these is already advanced. Exactly. So we are trying the best we can to see to it that every patient diagnosed with lung cancer gets treated. Okay. We do not do biasness. It doesn't matter your age, your sex, your region you're coming from, how advanced the disease is. We always try to mitigate. Okay. And we are hoping that we will not get to a place where we're mitigating as palliative, where you just ensure that pain management is done, rather than we mitigate with the intention to prolong life without pain, and to improve the quality of life. Yes. All right. For patients.
Now, at this point, I think that's where we could now discuss about the project, because the project, as you've mentioned, is about ensuring that you have the latest, most advanced options available for patients. So, just for reminder purposes, for those maybe who joined us later on, you had mentioned a bit about the project. Maybe you could just recap about what the project is, and the objectives, the programs that you have within that project, and who your target is.
Indeed.
Yes.
Thank you. Now, the Multinational Lung Cancer Control Program, as I mentioned earlier, is a program that is based within Mtrh and Faro Hospital. Okay. And it's part of the many programs that form what you call the Ampath Oncology, Ampath Mtrh Oncology and Hematology Directorate. We have our leader, we have a system that is working, led by Dr. Jesse Opakas. And this, we have various cancers that are being taken care of. And lung cancer is a part of it. Okay. Now, when it comes to lung cancer, funded by Bristol Myers Squibb Foundation, not the pharma company, but the foundation from it. The MLCCP, if I may call it in short, has a mandate, first of all, to drive an early diagnosis agenda. And with this, we just don't drive an early diagnosis per se, but to ensure that individuals who actually get diagnosed get access to the entire treatment and quality of care is improved. Now, what happens is that we have laid down strategies to penetrate the community. Remember, community is basically the backbone of health. So we have means on how we can go to the community at household level. We work with community health promoters to identify cough, simple sign, or chest pain, or difficulty in breathing at the household level. So if these are identified, the question the community health promoter asks is, have you accessed care?
For these
particular symptoms. If the answer is yes, and then the question is, are these symptoms going away or they are still persistent? If they are still persistent, then the community health promoter refers you to the next facility, not to Mtrh and Faro Hospital, to the next facility. So at the peripheral facility, we have built capacity with the clinicians and the nurses at those facilities to evaluate this case so that they can rule out whether it is TB or it's upper respiratory tract infection. Or if it's a lower respiratory tract infection, then does it have treatment? Have they treated? And all this cascade does not need to take too long. If a community health promoter has identified as you in a house with those signs, the next day should be at the next facility level. You are evaluated. And, and riding on what the treatment cascade is embracing is that we're realizing that this cascading helps, because then we don't overwhelm the system at the higher end of the care. We don't overwhelm the system, because we don't want patients who are coming to Moi Teaching and Referral Oncology Center with cough that is not related, that can be managed at the peripheral. Yes, that's not related to cancer. So at the peripheral facility, then we have clinicians who evaluate this patient, and if they can be able to treat, they treat empirically. If they cannot be able to treat, then they refer accordingly to the next level, which is now at Moi Teaching and Referral, because we don't want to have too many levels again. Because I'll say you, the clinician at Moi Teaching and Referral Hospital, I don't know which example I can use. Let me use Mosoriot, for example. And the clinician at Mosoriot, they are all clinicians. They are all nurses. They may have difference of systems that makes them different, because this one can access a city, this one cannot access a city. But they are all clinicians. They will say their evaluation will most likely be congruent to each other. So then this clinician refers to the colleague in Moi Teaching and Referral with the referral notes indicating that this patient has been evaluated. We are ruling out TB, tested for gene expert, TB negative. There's a clear indication on a chest X-ray that there could be a mass. Or if they've done a chest CT, then they could say we are recognizing a mass, then we are advocating for evaluation and possible biopsy. When that patient comes to Moi Teaching and Referral Hospital, he is received by our team and navigated through the system to make sure then that this particular patient is equally evaluated with the interventional radiologist after being evaluated with the clinicians within Moi Teaching and Referral Hospital. If they have not taken a chest CT or imaging, then they will take a chest imaging within the Moi Teaching and Referral Hospital. We're not going to send them back because they may not have it. So then when you do a chest CT and recognize there's a mass, then the evaluation process begins. They are evaluated to find out whether they actually have a mass that can be biopsied. Because remember I said tissue is the issue. The rest is rumor.
If you don't have a mass,
we don't say we don't have a tissue, then you can't say you have lung cancer or cancer for that matter. Then after that evaluation, the patient then goes through the entire cascade of care, including the uptake of biopsy. The samples are taken in for evaluation at the pathology lab. The results come back. When the results are positive, we further evaluate them whether they are EGFR positive or negative. If they are positive, we link up with our partners in AstraZeneca to ensure that these individuals get supported for the treatment. If it's negative, then we enroll them into our projects, into our program, in the wider oncology program, for them to get the current treatment with the chemotherapy or radiotherapy as reviewed and done by the oncologists, because we have a group, we have a team of oncologists and clinicians who ensure that this patient gets best of care. So that is basically what you're doing, and as a program, we're ensuring that the entire cascade is complete. Where there are gaps or challenges, we mitigate. Because I'll tell you, when a patient shows up at Moi Teaching and Referral Hospital and they cannot be able to afford a chest CT, we don't tell them to go back home and look for money, because they may never come back, and this disease will continue. So we're working together with the Moi Teaching and Referral to ensure that these patients are evaluated, and those who can absolutely not be able to afford are waived, and the project comes in to compensate, so that then they don't go home. So the project's, one of the main agenda is to mitigate these challenges by intervening with the mother institution to make sure that the patients, regardless of where they come from, access, meaning they can be able to be supported to come from their homes to facility. And then in the facility, they're also able to access the procedures. And if they turn up to be positive, then they're able to access treatment, meaning the entire cascade is literally taken care of to ensure that the patient's life is improved. Yes.
And the quality of life is improved.
Yes, indeed.
A few, I think, weeks ago, there was this function in Uasin Gishu where, along with the hospice fraternity, you were in some kind of partnership with the county government. I guess my question would be the scope of your project. Is this something that is just domiciled within Uasin Gishu? Do you know, because there are many counties that are in that, you know, net where MTRH draws majority of its patients. Do you, for instance, support people in Bomet County, in Kericho County, in Turkana County, or are residents of Uasin Gishu, you know, the sole beneficiaries?
Yeah. Thank you, Victor. Good question. I think I should have mentioned this earlier, but that's very good to bring it up. The lung cancer control program does not segregate a patient from whichever region. If they land in Moi Teaching and Faro Hospital and they are sick, we will see them. Okay. Even if they're coming from Mombasa, because you have patients who actually come from very far, Mombasa, Narok, everywhere.
Okay.
But you can also not operate as a program or a project without jurisdictional mandate. We are basically focused in 15 counties of Western region and North Rift. And that includes Nakuru, Uasin Gishu, Trans Nzoia, Bungoma, Busia, way down to Kakamega, Vihiga, Siaya, Homa Bay, Kisumu, Kisii, Bomet, Kericho. Yeah. We've been to Kericho, we've been to Bomet. But those are the areas where we actually go in to physically meet the people and create awareness on this, what you're doing, and make sure that then they can be able to link the patients they identify who are at risk, rather who are suspicious, to Moi Teaching and Faro Hospital for more evaluation. However, if a patient shows up, for example, today, if someone is listening in Nairobi and they say, I think I want to go to Moi Teaching and Faro Hospital to get further evaluation, as long as they have gone to a facility here and the facility has evaluated them. We like self-referrals, but we don't usually advocate for it. Why? Because we may have so many cases that do not necessarily need to come to Moi Teaching and Faro Hospital.
They could be handled
at the peripheral
dispensaries.
Yes, exactly. So we want you to be referred by an expert to us. If you are referred to us, come. Even if you're from Kilifi, you're from Mombasa, we'll make sure that you access the care and you walk through it. But generally, areas of catchment is the former Western Kenya, Nyanza, and North Rift. And those are the areas where we are focusing. If you look at all those areas, we realize that Uasin Gishu has come up to be the most outstanding area with many cases. Okay. But it's not because Uasin Gishu has more lung cancer than Kisii, for example. No. It's just that the project is based within Uasin Gishu, and therefore it is much easier.
The message has penetrated much more.
Yes, and access to the services of lung cancer evaluation is high, and it's made access. Many people will easily reach Moi Teaching and Faro Hospital from Uasin Gishu than they will do from Bomet. And therefore you find that Uasin Gishu cases are many. If this project or if this particular intervention was taken to Bomet, Bomet would become the highest in lung cancer. So what does that mean therefore? That lung cancer is with us. The challenge is finding it, and the more challenge is finding it early. So we are very optimistic that with time, we can be able to see many of the counties identifying these cases and referring these cases to Moi Teaching and Faro Hospital, and these cases being taken up for diagnosis and evaluation. You
mentioned that you have a presence in 15 counties, Western region counties. Seeing as the headquarters is in Mtrh, what sort of presence do you have in these other counties?
Indeed.
You know? And how has the reception been? Because, you know, counties, everybody wants to feel like they, you know. So are they receiving your project positively?
Indeed.
And if so, how do you position yourselves within the counties? Yes.
Now, one of the things that we realized as a project when we began is that we began as a cancer project, but we are all based in Moi Teaching and Faro. So we sat there and waited for patients to come. And they came, but they trickled in very slowly. And at one particular point, the deaths and the live patients were equal. So that means there was no patient. You understand? If I identified 5 patients last week, and this week I'm reporting 5 patients who are dead, then I don't have any patients. I'm at 0. Then we began to realize that it's because we have quote-unquote cocooned ourselves within the high end, the headquarter. So what we did was we looked at where do most of these patients come from? Where is the entry point? Then we realized The entry point is actually the TB clinic. Why? Because most patients who have cough, chest pain, difficulty in breathing will end up.
First port of call is the TB.
The TB clinic. When you find them in outpatient, you'll tell them, hey, this cough of yours is too much. Hebu enda hapo kwa TB clinic uangaliwe. So what did we do? We have partnered with all TB focal persons within all these 15 counties. Okay. We have partnered with them with one main aim. Identify TB. If you can't identify TB, refer it. Let's see what it is. And I'm not saying everyone who has not had TB has lung cancer. No, we're saying that find out what it is. And that's how we came up with the slogan, if it's not TB, what is it? Go for further evaluation. Yeah. So this county TB and leprosy coordinators, CTLCs, are key persons in these various counties that work with the project to identify the cases that are called stubborn, the cases that are not responding, the cases that are not heeding to treatment, to refer those cases to us for further evaluation. The reception has been great, because I'll tell you as a clinician, whenever I sit down to see a patient and the patient keeps coming, you see, I want sometimes to find a way where I can get rid of this patient so that the patient doesn't come back. Yeah. So it's a breakthrough. Most of the TB clinics are realizing, oops, we were stranded, because you treat a patient for TB, they come back with worse. Well, you're treating them clinically mostly, because if they come back and they are worse, and you keep treating them for TB, one day they will disappear.
And that's what people say, madness.
Yes.
Doing the same thing every
same way,
exactly
different results. So when you see the patient who have been treating for TB over and over and over, sometimes disappearing, it's not because they are healed. Most likely it's because they're no longer alive and they can't come. Yeah. So a breakthrough for the TB clinic, or the TB, what we call workflow, is if you cannot find TB in these particular patients, refer them. And we are not saying lung cancer cannot come with TB. We can actually have the two diseases together. Okay. So it means, therefore, if you have tested for TB and the gene expert is positive, treat this patient according to the TB algorithm. If the patient has finished the course of treatment, but you see that clinically they're not improving, they are coughing, now they're coughing blood, refer this patient. Don't stop the treatment. If you want to start whichever line you want, or even want to treat for multi-drug resistance, you begin. But take these samples for further evaluation as you refer this patient to us, so that you can be able to evaluate further to see, because it's possible for a patient to have TB and lung cancer together. Clinical management of TB is one of the things that we are advocating for, but we are saying, can you monitor this patient? In 2 weeks after you've started treatment, don't let the patient come 2, 3, 4 times for you to finish the dose when they are not improving, especially if they are adhering to the treatment. If these patients are actually adhering to the treatment and they're not improving, don't stop their treatment. Refer them with their treatment to Mtrh and Mtrh. So we'll do a chest CT to find out whether there is a lung mass. Then see what you can be able to work on. So it's very imperative that the TB clinic, the chest clinic, any other place that deals with the chest aligns itself to say, if this is not the condition I'm looking for, what is it? It could be lung cancer. So then now we can be able to work together. But the reception has been great. We've been highly received in Bomet, in Kericho. People in Kericho are very excited. We are very glad because they are ready to embrace this initiative. And we have one of our long-serving patients, surviving patients, actually comes from Kericho County. Okay? And we understand the distance from Kericho, from Bomet, from Kisii. It's not easy, but you have patients who actually come all the way from those particular areas to come and get treatment at Mtrh and Mtrh Hospital. And we really appreciate that.
Yeah.
Yes.
And we appreciate the work you're doing in the project. And we hope that more and more people become curious to find out just how healthy their lungs are.
Indeed.
You know?
Indeed.
Cold season, rainy season,
Indeed.
coughing.
Yes.